the webinar that we have this evening with Dr. Harry Karpouzis of Pelargos IVF, who is going to be talking for us this evening on a very important topic when you are planning any form really of assisted conception, on understanding your ovarian reserve and its effect on your present and both present and future fertility. He's speaking on behalf of us at the European Fertility Society, and I am Barbara Scott. I'm chair of the Association of Reproductive Reflexologists. Absolutely delighted to have Harry with us again, Dr. Harry with us again this evening, who has spoken on many really important topics for all of you, things that are helping to inform and shape your journeys to parenthood. So we're delighted to have him with us this evening. Before we begin, I just want to say, please do use the chat box to ask any questions that you may have. You will be anonymous. Sometimes I do just use first names, but you will be anonymous, and we will go through as many of the questions as we possibly can during the evening. If we do run out of time, then what we will do is make sure that they are passed on, and you will get some answers back to you. So thank you for joining us, and I wanted to hand over to Dr. Harry, who is going to speak for us this evening. Thank you so much for being with us.
Thanks, Barbara. Nice to see you again now. Let me introduce first. I'm Harry Karpouzis. I'm the scientific director of Pelargos IVF. We are a fertility group, a fertility clinic based in Athens, in Greece. And today we will talk about ovarian reserve. What it means for the present and the future fertility. A very important topic because everything in IVF starts actually from the ovarian reserve. We have a small issue in changing the slide, so I will need to be saying in every slide to go to the next. So if we can change to the next slide. Okay. Let's start about what is ovarian reserve. Ovarian reserve actually shows the number of eggs left in the ovaries. It also says things about the quality, but the number of the eggs does not has to do anything with the quality. Quality can be different from the number of the eggs. I mean, you can have a small number of eggs and you can have increased quality, or you can have a big number of eggs and the quality being decreased. Sorry, I have lost the presentation, so I need yeah, okay. The quality depends mainly on one issue, and this issue is age, on one factor, and this factor is age. The number of the eggs, the number of the eggs that we can get actually in one IVF attempt, it depends on the antral follicular count. It depends on the AMH, and it depends on the FSH and other factors like that. We have an issue because the presentation disappears in front of the screen. So I need to have the presentation big. I can see only myself. Okay, all right. I can see now the presentation, so let's continue. So the ovarian reserve has to do with what happens now, actually. So let's ask the question, what does the ovarian reserve tell us and what doesn't tell us? Ovarian reserve tell us how well an ovary will react to a stimulation. It can tell you if we are in risk of not having a good response, or if we are in risk of having an excessive response, which sometimes can lead to hyperstimulation. It actually gives us prediction about what protocol we will choose to decide a tailor-made protocol. It can also predict the higher number of eggs that we can retrieve in one stimulation. What I always say is that we cannot stimulate follicles that we do not see in the initial scan that we are doing in the beginning of an IVF cycle. An IVF cycle starts usually on the second day of the period. We see how many follicles we have at that time. And given of that, we get a prediction about how many eggs we can get in one go. The ovarian reserve does not tell us when the menopause will come, because it's a very common question. I have low AMH. Will my menopause come soon? Well, yes, you might have a bit of higher chances for that in comparison to a woman that has a normal AMH, but it cannot predict when the menopause will come. It might come in 2 years, it might come in 10 years. And also, the AMH does not tell you if you can get pregnant or not, either with IVF or spontaneously. Definitely, it makes things worse, but if the AMH is a bit low, you can still get pregnant. And the main thing actually in IVF has to do with the quality of the eggs. And the quality of the eggs depends usually in one factor, and this factor is age. We can change to the next slide. Okay. So the ovarian reserve is definitely related to age. And we know for sure that as someone is getting older, it drops down. What other things can it depend on? It can depend on previous surgery in the ovaries, because, for example, when we have removed cysts before, or when we have removed one of the ovaries, obviously the ovarian reserve is lower. It can be related, and there is evidence for that, to endometriosis, a disease that is causing painful periods and pain in sex. It can be related to genetic disorders. There are some genes actually that can relate to poor ovarian reserve, and also chromosome abnormalities. It can be related to polycystic ovaries, either in the past, a woman that had polycystic ovaries in the past, or in the present. Women that have polycystic ovaries, they do not ovulate a lot. So when you do not ovulate a lot, you don't lose eggs. So one of the good things of polycystic ovaries is that as women with previous polycystic ovaries are getting older, they are having actually a better ovarian reserve. And ovarian reserve can vary between women. We have women of the same age that without any reason that we can understand, they have better or worse ovarian reserve. Let's move to the next one. Okay, some very interesting statistics to understand what is happening. I mean, the eggs are constantly going down, but how many eggs do we have on birth? On birth, a woman has 1 to 2 millions, and the eggs have already started going down, because in 20 weeks of gestation, there are about 6 to 7 millions. And then in puberty, when a girl is having the first period, we have around 300 to 500,000 eggs. And then it keeps going down. And in 30s, it goes down to 100 to 150K. And then when someone is 35 years old, usually the number goes more down to 25 to 50,000. And when someone is getting to 40s, it goes even more down to 10 to 15,000. And then when someone is going close to menopause, can go down to even less than 1,000 or 100, even sometimes eggs. We see that there is a constant drop, and actually the drop is not like in a normal way. The fertility goes down slightly after 35 and dramatically after 38, 40, and after 40 even more dramatically. And to understand what is happening, I mean, we will have only 400 to 500 eggs ovulating during the whole life of a woman. And the rest go to atresia. So actually what is happening is that most of the eggs are naturally programmed to a cell death. And only 400 to 500 of these eggs actually ovulate. We can change the slide. Okay, let's talk about AMH, antral follicular count, two very important things. Okay, AMH, what is AMH? It's a very well-known hormone. Everybody talks about AMH. It's a hormone produced by the granulosa cells, and actually, to understand, it is produced by the small antral follicles, the small follicles, not the big follicles. So actually, it's a biomarker of how many follicles we can retrieve in one IVF cycle. It doesn't show how fertile a woman is, and it doesn't show if a woman can get pregnant or not. A woman with high AMH can get pregnant. A woman with low AMH can get pregnant. It does not say anything about the quality. The quality depends only on one factor, and this factor is age and genetics. It can be measured at any day of the cycle, because women ask sometimes, oh, do I need to do it on the second day of the cycle? No. And it always declines with age. Yes, we might have some women, because it's a very difficult test in the laboratory, that have done an AMH and then they have repeated, and it is a bit higher or a bit lower. Okay, discrepancies like that in the laboratories is normal, but the truth is that if you further analyze it, it can only go down. And also, it has a very low intra-cycle variability, which means if you check it in the beginning of the cycle to the end of the cycle, it doesn't make any big difference. Next slide. Can we change the slide? Yeah. So, I mean, AMH, first of all, we need to be a bit careful, because in some of the countries, they measure it in picomole per liter, in some of the countries in mg per ml. Generally, in the basic and most common levels, when it is less than 0.5, it usually shows a very low response. Between 0.5 and 1, it shows a low response. Between 1 and 3.5, it is considered to be normal, and more than 3.5 to 4, it is considered to be a high response. We are saying again that AMH does not count the eggs. Okay, it correlates though with how many follicles we can recruit in a cycle. It does not predict the quality. We need to repeat that, and it can predict in a way the chances of achieving a normal egg. When we say a normal egg, we mean an egg that with normal chromosomes. This depends mainly on the age, but because the AMH correlates with the follicles, the more follicles we have, the more eggs we might get, and the more eggs we might get, the more statistically the chances of one of them being chromosomically normal. So it is an indirect relation to achieving a normal egg. It is actually something that shows how many eggs we can get, and the more eggs, the more we increase statistically the chances of one of them being chromosomically normal in an IVF cycle. Next slide. Okay. AMH definitely helps us in the protocol. We work a lot with antral follicular count, but we always take into consideration AMH. And AMH and AFC need to be taken into consideration both. When we have a high AMH, usually we use a short antagonist protocol in IVF, because otherwise we might be in risk of hyperstimulation. Even if we freeze sometimes, of course, freezing has minimized the possibility of hyperstimulation nowadays. When we have a normal AMH, we can play around with the protocol. In our clinic, we mainly use short antagonist protocols, but in some very special occasions, like not good coordination of the follicles, etc., we can also use a long protocol if the AMH is normal. And the problem is usually with low AMH, because more people with low AMH are going to IVF. We can use a short agonist protocol. We have the short flare protocols. We do the double stimulation protocols. We do some special protocols that have to do with increasing the androgen levels inside the follicles. We can also start sometimes in the second half of the cycle, a luteal start protocol. And we can decide if we will do a high or a low dose. And this depends on the antral follicular count too. A question that they several times ask me, can AMH be increased? I mean, we don't have a magic way of increasing AMH. DHEA had some small evidence, it's getting less and less. Coenzyme Q10 mainly improves the quality and not the number. NMN, which is a precursor of NAD, and we use it several times in poor responders, can help also with the quality, but it doesn't have any evidence that it can increase AMH. The same with resveratrol. Growth hormone also is correlated mainly sometimes with the quality, and even with the quality, it's not confirmed 100%. And we have some treatments like stem cells and PRP that we will talk later as well, that might slightly improve the AMH and the antral follicular count. But even these treatments are not directly related to increase in the pregnancy rates, and we will talk about that later. Can we change the slide? I want to travel somewhere, most probably. Okay, antral follicular count, it has to do with the number of the follicles, how many follicles we see in the beginning of the cycle or in the second half of the cycle if we start on the second half, because sometimes we start on the second half as well with the luteal phase protocols. A very important thing here that it is not said often, does the size play a role? Yes, it does, because we have follicles sometimes in the beginning of the cycle that are less than 5 millimeters and follicles that are between 5 to 10 millimeters. And it makes a difference because sometimes follicles less than 5 millimeters are primordial follicles that they do not develop into proper eggs, even if we try to trigger them with very high doses of medication. The follicles between 5 to 10 millimeters are easier to get. When we have many small follicles, sometimes we prefer to go high on the doses of the protocol because otherwise they will not be triggered at all. Even if we go high, though, some of these follicles will not be triggered and will not develop. Antral follicular count usually corresponds to AMH. So if AMH is low, AFC is low. If AMH is high, AFC is high, but not always. Many times we can see that the AMH is a bit better and the antral follicular count a bit worse, or the antral follicular count the opposite. A very important thing that we use in Pelargos IVF, we have a cutoff level limit actually between less than 4 to 5 follicles and more than 5 to 6 follicles, and this plays a very important role in selecting the protocol of choice. And AFC is very, very important, and the information that we get is very important, and it is the most important direct predictor of the egg yield, which means that out of the number of the follicles that we have in the beginning, on that cycle, a specific cycle, it can predict what is the maximum number of eggs that we can get. We might get less than that, but we will not get more than that. We cannot stimulate follicles that we do not see in the beginning of the cycle. Next one. FSH, it was used more in the past. It is cycle dependent, so it needs to be measured on the 2nd to 4th day of the cycle. Many times I see FSHs and I don't see estradiol. We need to have estradiol to evaluate an FSH, because if the estradiol is not low, the FSH, it's not evaluated correctly. It is less predictive. One high value of an FSH does not predict a permanent failure, a menopause, but if it is repeated again and again, it does show diminished ovarian reserve. It can vary between cycles. So in one cycle, it can be 25, and in the other cycle, it can be 10. And when the FSH is more than 20 to 25, there is a very high cancellation risk. So in women that play around with the FSHs, it is better to start the cycle, if possible, with a cycle that has an FSH which is lower rather than higher. Next one. Okay, what is more important? I've said before, both are very important. Both predict the response. It is better to use them together. We believe a lot in annual follicular count, a bit more than AMH, but we use it in our practice. And actually, when we have less than 4 to 5 follicles and a low AMH, we usually prefer low dose protocols or semi-natural cycles or banking, which means repeated cycles, or luteal start, or some special mixed protocols with letrozole, clomiphene. When the follicles are more than 6, though, it means that if you give a higher dose of medication, you can get more eggs. And given of the fact that the more eggs means more chances, we prefer to go this way. So when we have enough follicles, we prefer to start high. When both of these factors are low, the pregnancy is still possible, but it is more difficult, yes, and the age plays the most important role. Okay, and as I said before, statistically, the more eggs we get, the more we increase the chances, especially in ages more than 40. Next one. What happens when we have low AMH and low AFC, antral follicular count? We usually consider repeated cycles, bank embryos, unless we do PGTA and we find the chromosomically normal embryo. In this case, we can decide that this is a very precious embryo and we can transfer it back. Sometimes, as I said, we can start on luteal start, second phase of the cycle, because sometimes the AFC is better on the second stage of the cycle, so we prefer to start there in order to get more eggs. We do double stimulation protocols. People keep asking me about double stimulation protocols, and I always say that we cannot predict if double stimulation is the best protocol unless few days before the egg collection, the first egg collection, because if at the time of the first egg collection we don't have enough remaining follicles, this means that it is not good to start a second stimulation straight away. It might be better to wait for the next period and start on the next period. Sometimes we consider also protocols with letrozole because letrozole can increase the androgen inside the follicles, and this has some evidence that it can help with poor ovarian responders. And we always use, people that knows us know about that, individualized approaches. The next one. Okay, and what happens when it is high? So usually when both of them are high, we are talking about polycystic ovaries or women that in the past had polycystic ovaries and it is getting better. We use always antagonist protocols. We always freeze. We use agonist triggers to reduce the chances of hyperstimulation. We check LH and estradiol throughout the cycle in every single ultrasound. It is very important to check LH as well, not only estradiol. And we individualize the doses in cases like that. We might start only with a medication which is called Ovalip or Gonalef, and then add Meriofert if needed, omit the antagonist, give full dose of antagonist, half dose of antagonist. It depends. If we measure the levels, it is very important to bring all the follicles at a stage that we will manage to trigger and get a good maturity rate, because the problem in cases like that is to get enough mature eggs. Next one. Okay, very common question, high or low dose in the protocols. I said it before, less than 4 to 5 follicles and low AMH, usually it is better to go with a low dose protocol rather than high dose. If we have more follicles, we prefer to go with higher doses to get more eggs. Most of the time, the more eggs, it means more chances. But higher doses of medication do not always mean higher quality. So when the quality is not persistently good with high doses protocol, then we can change actually the approach to lower dose protocols. Next one. Okay, let's talk a bit about ovarian PRP and stem cells. I mean, we've been doing these treatments for a long time. Ovarian PRP, it's a treatment that we take the blood, we centrifugate it, and we create growth factors and cytosins, and then we inject this sample inside the ovaries. And this is supposedly causing increase in the AMH, reducing the FSH, and a bit of better antral follicular count. It's not proven, but we have very good data behind that. And 80% of the patients do react, do improve, especially in younger ages. The quality, though, we cannot say that it is really affected. We cannot prove it. And does it increase the pregnancy rates? We cannot prove it. So we are talking about experimental treatments that might help, though, increase a bit the hormonal profile and getting some more eggs. Regarding the supplements we talked before, lifestyle, decrease alcohol, smoking, vitamin D always helps. And growth hormone, it does not really increase the AMH or the AFC, but in some of the protocols that we have very low quality, we can use it because it can help with that. And actually, it can help get more mature eggs as well in some of the cases that we have this issue. The last slide, I think. Yes. So, markers guide the protocol of the IVF. Markers is the AFC and the AMH, but not the destiny of someone if someone will get pregnant or not. Age is the most important factor, and we cannot change that, unfortunately. The markers do not affect the quality. AMH and AFC does not affect the quality. In advanced ages, especially more than 40, more eggs, more chances of finding the one egg that is the lucky one. PGTA, pre-implantation diagnosis, checks the euploidy of the embryos if they have normal chromosomes or not. Don't forget about the sperm. In the embryo, we have the sperm as well, and it plays a role. The better the sperm, the better we select it, the more the chances of an embryo having normal chromosomes in the end. And the number of the eggs in one cycle can be predicted by the number of the initial follicles. And in the end, personalizing the whole approach can make us get the best that we can, given of the genetic material. We cannot change the genetic material, but we can try to get the most that we can. That's it.
Thank you so much. That was just, you've crammed a lot into a very short space of time. That was so informative. We have got quite a few questions in, but I'm just going to say, from what you're saying, it sounds as though really the key to all of this is age and an individualized approach, and that AMH, FSH, and antral follicle count scan really are guides in terms of what treatment would be the most, or the drug protocol would be the most appropriate for that individual. Am I right in saying?
Yes, I mean, AMH and AFC actually can help us a lot with the protocol and can predict the number of eggs that we can get in one go. The quality depends on age, and we cannot change that. But we have some ways of increasing the number of the eggs, given of the number of the follicles that we have, in order to increase statistically the chances of getting the one egg that will be chromosomically normal. And obviously, if someone is close to 40 needs a higher number of eggs to be lucky. When someone is less than 35, even 8 eggs can give very good chances.
Yeah, and I'm guessing also it is about reducing the risk of miscarriage and children with chromosomal anomalies.
Yeah, I mean, miscarriage also changes related to the age. Yes, we know that even in young women, we have a miscarriage rate of 15%. When someone is 42, 43, the miscarriage rate can go as high as 30+%. Okay, and one way to circumvent that is in these age groups to do the PGTA testing, reducing the chances of miscarriages, but not eliminating, because miscarriages do not always depend on chromosomes. Sometimes we have other reasons as well.
Yeah, absolutely. So important. We have actually got quite a few questions in, but one question I did just want to ask, we seem to have moved away from it now, but there was a point in time when a lot of clinics were offering a kind of fertility MOT, which was testing AMH and AFC. And I mean, I think it does still happen, but not quite in the same way. And I just wondered, whether you had a view or opinion on that. And I think I probably know the answer from listening to you this evening. That certainly, patients that we listened to were using that as an indicator for whether A, they could get pregnant naturally, and B, how successful, their cycle of treatment was likely to be.
You mean to check the anti-Mullerian hormone and to check the andral follicles? Yes. Well, yes. I mean, it's good. First of all, when women are having their pap tests, I mean, it is good to have an ultrasound as well. And it would be very good in this ultrasound, the doctors that are doing the ultrasounds, to have a bit of reproductive knowledge as well to measure the follicles. Because when you see, for example, in a 32 years old woman, a very reduced number of follicles, then you know that this woman, if delays pregnancy, will have an issue. So you can suggest to this woman to freeze the eggs. So, I mean, yes, I mean, women can check about the AMH. This is not a predictor of if they will get pregnant or not, okay? Because women with low AMH, if they are young in age and they find someone and they try in the next 2 years, they might get pregnant, okay?
Mm-hmm.
But it is a predictor that, listen, if I don't go into pregnancy in the next 2 years, my AMH might get lower, my AFC will get lower, so it is better either to freeze my eggs or hurry up. Okay.
Mm-hmm. Yeah, no, absolutely. It allows them to make informed choices, which is really important. Okay, I'm going to start asking some of the questions. I think we have quite a few. Some of them look slightly more complicated. So Deb has asked, what are, I think it's examples of agonist triggers, please, and what is meant by an antagonist protocol for high AFC and AMH?
What are examples of agonist triggers? I mean, agonist is, when we say agonist, we mean a GnRH agonist. Okay, we trigger usually with two different medication. One of them is HCG, which is the Ovitrel, okay, and one of them is the GnRH agonist that has different names. I mean, in Greece it has the name of Arvecap. It can be Suprefact. It can be in different countries different names. When we have high estrogen levels and high progesterone levels, and especially with polycystic ovaries and things like that, if we give Ovitrel, we increase the chances of hyperstimulation. So we prefer to give agonist trigger. The problem with the agonist trigger is that if we give an agonist trigger, we need to freeze. But nowadays, with frozen cycles, we have equal or even better chances of success in comparison to fresh because we vitrify. So we are not afraid of freezing. And sometimes when the estrogen levels go very high in a protocol, we prefer to freeze and wait for the hormones to cool down in order to have better chances of success, because otherwise a fresh transfer will not work. So this is the agonist trigger, and this is the big benefit. A, it reduces the chances of hyperstimulation, and B, depending on how much agonist trigger we will give, can get some better yield. Okay, Ovitrel is an important medication as well, but we can use it either in combination with agonist or by itself. If we go for fresh transfers, we definitely need to use Ovitrel as well.
Mm-hmm. Perfect. That's great. And I'm guessing it kind of leads on from a question that I wanted to just clarify, which was your protocol for women with PCOS, that kind of freeze all, and then I'm guessing a frozen embryo transfer, which provides a better outcome for that very reason. So I think that probably answers that question very nicely, actually. So great. That's lovely. Thank you. The next one is from Melissa. So what levels of AMH will be needed for IVF? And is there any way you can improve the levels? Well, really, you've actually already answered
Yeah,
those.
I've said in the presentation there is no levels of AMH. I mean, anybody can have IVF. Okay, obviously when the AMH is low, the chances are more difficult. You will not get a lot of eggs, especially if it corresponds to low antral follicular count as well. But this is one more reason, if you are in a good age, to expedite IVF so that you can try and get some eggs, because later on the AMH will be even lower. The levels of AMH, I've said in the presentation, there is no miraculous way to increase. As you are getting older, they are getting usually lower. I mean, treatments like PRP and stem cells, if we are talking about very low AMH and high FSH, you can try it, and it might help. It might increase a bit the levels. We have some data behind it. It's not randomized, it is not conclusive, but it is strong data.
Wonderful. So, do you feel yet that we have enough data on cycles that follow on from frozen eggs? Because we have an increase, don't we, in women who are freezing their eggs to preserve their fertility. And I think the data I've read so far is that we don't really know quite how many of them are going on to eggs. They may be that they're continuing with a fresh cycle. But I just wondered whether you felt we had enough data in that particular area to provide women with informed choice, really, in terms of egg freezing. I know we're going off topic, but it just seemed to flow in quite nicely.
Yeah, I mean, egg freezing nowadays has very good chances of success. I mean, we vitrify eggs as well. So given of the number of the eggs and the age that we have frozen the eggs, it is very important. I mean, the difference is between 3 to 5% in each age group in favor of fertilizing fresh eggs in comparison to frozen eggs. It's not a big difference. I mean, if someone freezes the eggs in 34, will have much better chances in comparison to having a fresh eggs IVF in 38.
Yeah, absolutely. Absolutely, that's lovely. Thank you. Okay, so the next one looks like lots of questions, so I'm going to try and break it down. So would it be better to do ovarian cryopreservation first and then ICSI and freezing in the following cycle? Or is it better to do it the other way round? That seems like the first part of the question.
Yes, I always say that, especially if we have a bit of lower ovarian reserve, that it is better, if possible, to fertilize the eggs, the fresh eggs, create embryos, and then you can bank the embryo rather than the egg. Okay, we prefer it in our unit. It gives us a bit, not big difference, but a bit of better chances of success. And also, if someone proceeds in PGTA, gives you also the advantage of finding out if this embryo that you will create is chromosomically normal or not. Because if you achieve a chromosomically normal embryo, it gives you very good chances, and it might tell you that, listen, I stop. I don't need to collect something else because I have an embryo. It gives me good chances. It is euploid. It has normal chromosomes. So I would say that I prefer to fertilize the fresh eggs and create embryos and bank the embryos. Now, regarding the PGTA, which is the second question, the PGTA checks chromosomes of the embryo, okay? It doesn't check about genetic diseases. This is something else. It is called PGTM, and you need to have a known disorder, a known genetic condition, and you can check for this one, okay? But you cannot check for all of them. Down syndrome is a chromosome condition. So yes, you can check the embryos for the chromosomes, and it might come back as a Down. So you don't put it back. Lots of questions. So
lots of questions. The next one is, I think she's talking about if it's I'm guessing O rhesus positive. Is it better to choose a specific group for the donor?
The blood group doesn't have any big. I mean, it's not our topic, but it's not. It doesn't give you any problems. I mean, if the person is rhesus negative and orders a donor that is positive might need to take some special injections during pregnancy. Same way is important,
Yeah.
I mean, to check it, to see what eggs you will choose or what sperm. Double stimulation. First of all,
I think,
I mean, this is not
yeah.
accurate because when we say double stimulation, we mean usually, by definition, two stimulations in one cycle. So after the collection, straight away to start the second stimulation. This is called double stimulation, and it can happen even in one cycle. Now, many times we don't do that, and we freeze the embryos, and then we do banking, which means in the next cycle we collect some more embryos, and it goes like that. Yeah.
Yeah, perfect. That's lovely. Thank you. Okay. Can HGH help improve follicles, and can a combination of Alonva, Spanish stimulation, Fergovaris, and Seren help a 40-year-old with low AMH?
Yeah, most probably about growth hormone. I explained few things about growth hormone. Growth hormone does not have an evidence of increasing the number of follicles or the AMH, but it has some data in poor ovarian responders that have problems with the quality as well or the maturity of the eggs. So we are using it as well in some of our cases, especially cases that have repeated failures and bad quality.
Okay.
Now, the protocol, every clinic chooses their own protocols. Pergovaris is a medication that we use it sometimes, but not often in our clinic. I mean, yes, Pergovaris is a very good medication if it is used correctly. So, Elonva as well. I mean, it's a medication that many clinics use it. We don't prefer a lot Pelargos IVF Elonva because we cannot regulate the blood tests in every single ultrasound, and we cannot change the doses. But I mean, every clinic has its own protocol, so you will need to discuss it and decide what is the best for you. The most important is to know that it is not one protocol fitting all, and the clinics just change the protocol depending on the clinical case. Yeah.
So that might be a case really where it might be helpful if she contacted you directly to just talk about her own circumstances.
Yeah, I mean, if she wants anything, she can of course contact us. Of course.
Yeah. Someone asking whether you're considering nutritional therapy in your practice.
Yeah, we don't delay treatments, especially with poor responders, in order to have dietitian treatments because there was like a craziness on that. And I was seeing that people were delaying treatments when the most important factor was actually age, in order to put some new supplements and vitamins in the diet, but to be in a healthy lifestyle and to have a dietitian input if needed. With antioxidants and everything, we do it, and we have a dietitian in our fertility group as well. So, in cases that are needed or asking it, yes, we do put it in. Yeah.
That's great, thanks. And then we have Ifat. I'm turning 45 soon, 6 failed IVF cycles, want to improve my ovarian reserve. I've heard about ovarian rejuvenation treatments such as stem cells, which we've been talking about, PRP. And my question about these treatments is if they can be really beneficial to improve quality or number of eggs and ovarian function.
Okay. 45 by definition makes things very, very difficult. Okay, the chances of success of a live birth in the age of 45 are very reduced. I've said before in the presentation, and I've repeated it later, that we need to be very honest. We work with PRP and stem cells and all these treatments for long, long time. But we are always honest to the people that are asking for it. If someone is doing it in order to improve the quality, okay, we have a small trend towards improving the quality, but we cannot prove it. And when you cannot prove something in science, in medicine, it's considered experimental, and you cannot say to people that it improves quality. And not us, I mean, that's general data. So it is not proven that it can improve quality. None of these treatments. Does it increase the chances of a live birth? No, because if it was increasing the chances of a live birth and we were proving this, we could prove this statistically, it wouldn't be considered an experimental treatment. Why we use it? Because we do have evidence and we do have data that these treatments in 80% of the cases might improve a bit or more the number of follicles, make better the AMH, and reduce a bit the FSH. So we use it in women that have FSHs of about 20, 25, 30, 35, and they want to bring it down because otherwise they cannot start a cycle. Because if you start a cycle with an FSH of more than 25, it will not work. It will lead you to cancellation. So these women, we always advise them that your chances are much, much better with egg donation. They will not increase your chances of pregnancy. But yes, if you want to achieve and you are not ready to go to egg donation and you want to achieve 1 or 2 eggs more, maybe this 1 or 2 eggs more will increase a bit the chances of being lucky. Your chances, though, of being lucky in the age of 45 are very low.
Yeah. I think the important thing to say there is really thank you for your honesty, because it is so important for patients. You know, they are bombarded with information, which sometimes can be very difficult to hear and very difficult to take on board. But actually, you know, information is really important in terms of being able to make sensible, informed choice. So,
Listen, Barbara, I mean, you cannot push a woman to go to egg donation because this is a very personal decision. Okay, you can only, as a fertility consultant, be honest about the chances and the statistics, which do not change. They are accurate. I mean, we say to people that in the age of 46, 47, your chances, PRP or not PRP, are less than 1%. Okay, and this 1% for them might be some chances. Okay, as far as this a consented decision, okay, it's okay. You can give it a try. We had a live birth in 47 as well, but it was one live birth in the last 3 years through IVF.
yeah.
Okay, with own eggs, I mean, of course. Um, so
Yeah.
we can do the best that we can, all the data that we can, and all the data that we use, being honest to patients about what they can really do. And then the decision is patient's decision, okay, as far as they have a consented decision.
Yeah, absolutely. That's what's so important. Okay. I have one frozen embryo from 2 rounds of fertility preservation, second round ICSI, pre-cancer treatment. I've been on Zoladex injections for 3 years and stopped. My fertility clinic tested my ovarian reserve and told me I had an AMH of 3.6, 5 to 10% chance of conceiving a follicle. The test was done 1 month stopping the Zoladex. I now have regular periods for the last 8 months. Will my ovarian reserve or AMH have changed? And is it worth asking for this blood test again? We don't know age. That's the only
Yes, we
thing.
don't know the age. That was I was trying to say. I mean, 3.6 also. It's what 3.6 ng, 3.6 picomole, because ng is high,
Yeah.
picomole is low.
Mm.
I mean, the chances, everything, it depends on what exactly is the AMH and what is the age. But to the question if my ovarian reserve can have changed, is that yes, as the time goes by, the AMH might change and might go down. It will not go suddenly up.
Yeah.
Depending on the age and depending on the rest, maybe it will be the best thing either to go and stimulate something to get something more, or if we already have an embryo from a much better age before the treatment that she had,
Yeah.
I don't know when she wants to go and transfer it inside. It depends on her history, her medical history. So we are missing a bit of the medical history in order to answer that. Yeah.
The key bit, absolutely. So I'm going to suggest that she emails you directly, and then she can have a direct conversation with you, which might, yeah. We have another one which is a bit nebulous as well. So this is, I have a polyp. Is this going to affect my fertility, and is it better to be removed? And again, we've got
Yes, yes. Polyp can affect, depending on the size as well, but generally, when we see a polyp, even if it is a small polyp in a woman that is trying for a pregnancy, it is better to remove it because it can increase the risk of miscarriage, it can reduce slightly the chances of implantation. So when we know that we have a polyp and someone is trying for a pregnancy, remove it, yeah.
Okay, perfect. What is the normal rate of decline for AMH?
No one knows, but I mean, after 35, it starts getting lower. After 37, a bit more, and after 40, it goes down dramatically. So an AMH of like 1 point something in 42 for the specific age is considered to be a good one. Okay, but an AMH of 1.2 for a woman that is 34 is not a good one. So it varies from age to age, and someone in sometimes it might have a small drop, but in sometimes it might have a very dramatic drop, and no one understands why.
Yeah, wonderful, thank you. And someone else, I mean, this is a big question with very little information, but I try IVF at least once with my own oocytes at age 46.
As far as you understand that in the age of 46, things are very, very, very difficult. And as far as your hormone levels make it doable, which means that FSH is okay and AMH is not very, 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 very low, and we do have some follicles to stimulate, and if you don't want to jump to egg donation, that egg donation will give you much better chances, yes, you can try it. You never know. Okay, yeah, we have seen women even with one egg getting pregnant, but you need to know that you will be spending money and time for something that will give you very low chances of success. We can do our best to make it happen, but we can reach up to a stage without really changing the genetic material.
Yeah, wonderful. So refreshing to have such an open, honest dialogue. We've just got one more, which is, I think, two more. So we were asking for more information on the very long question, and we didn't know whether AMH was PMOS or NGs, and actually she's come back very kindly. So she's 40, 3.6 PMOS and 2 antral follicles.
Yeah, it's low. As the time goes by, this will be getting most probably lower. Given of the fact that you have 2 antral follicles, it means that if you go for an IVF right now, most probably in one go, we will not be able to get more than 2 eggs. You might need more than 1 round in order to collect more eggs. If you are thinking and your doctor allows you, given of your past history and everything, to go with new stimulations, it is better to expedite stimulations and collect some more eggs now rather than later, because it might become worse. Yes.
Yeah, so bank them. So yeah, so you've got some banked embryos. Great, lovely. And then the final one, which I think has come in, is someone asking, I have a fibroid, even though it's not in a position that's uncomfortable for a pregnancy, is it always better to remove it before doing an embryo transfer to avoid risks?
It depends on the size and the position. If it is a fibroid that is protruding inside the cavity, or it is inside the cavity, it needs to be removed. If it is a fibroid that it is in the muscle of the womb or outside the womb, usually we do not remove it unless we are talking about many and big fibroids. And even with many and big fibroids, there is conflicting evidence behind if we really need to remove it at the time of the first transfer or not. But usually when we have big fibroids, we prefer to remove it. When they are fibroids less than 5 centimeters and they are not going inside the cavity, we leave them.
Okay, perfect. I hope that's really helpful. Wonderful. you've whizzed through lots of questions this evening. Thank you so much. Really, really insightful. And the thing I love is just the transparency, because actually that just provides people with information they can use and they can make their own informed choice. So wonderful. Thank you so much for being with us. It's been a really lovely session this evening. Really. As always, Harry, it's always lovely to spend time with you, and I love listening to your ways of explaining actually what are quite complicated pieces of science. So it's really lovely to be able
to. Barbara, you are a lovely host always, and I hope I helped. And any questions, anything at all, do not hesitate to contact us at Pelargos IVF, and we can always help you have a chat and discuss about IVF cases. Okay.
Wonderful. Thank you very much. I'm sure people will be in touch, because there are some questions there, I'm sure, that could do with some more detailed answers directly. So wonderful. Thank you everyone who's joined us live, and thank you everyone on behalf of European Fertility Society for listening to this either live or on catch up. It's been great to have you with us this evening. Okay. Take care, and go and have a lovely evening. Bye now. Bye.